If you've trained at more than one hospital, you've probably seen this play out. Some attendings always pick misoprostol for induction of labor. Others swear by Cervidil. Plenty of folks place a Foley whenever they get the chance. And sometimes we mix and match methods. But the real reasons behind those choices are not always clear. I ask residents all the time, why did you pick that method? And the answer is usually, that's what my supervisor does, or that's how we do it at the other institution. As someone who trains residents daily, I have to rely on data, not preference. We all know prostaglandins are a no-go with prior uterine surgery, but in an unscarred uterus, which method is safest? Which works best? Which is most cost-effective? If you do not know those answers, this video is for you. I looked at clinical trials on induction methods over the last 2 decades. In the next few minutes, I'll give you a practical, evidence-based framework to choose the right induction method for your patients. So, question number 1. Which method is the safest? Mechanical methods often lead the pack here. Foley catheters have the lowest rate of uterine hyperstimulation in trials, which is why they are the go-to for patients with a previous C-section. A large meta-analysis from 2015 found this pattern across 96 trials. A newer review from 2022 also showed fewer adverse perinatal outcomes. Interestingly, maternal outcomes like cesarean rate did not really differ. Now, if the cervix is closed and a catheter simply is not feasible, your next safest option is oxytocin. Its half-life is short, and you can turn it off quickly when needed. For TOLAC patients, oxytocin carries lower rupture risk than prostaglandins. But if there is no previous C-section and prostaglandins are appropriate, you need to know what the evidence actually shows. You may hear that Cervidil is safer because you can remove it, but removable does not automatically mean better outcomes. A 2023 meta-analysis of 39 randomized trials found no differences between misoprostol and Cervidil in cesarean rate, instrumental delivery, tachysystole, postpartum hemorrhage, or neonatal outcomes. Even in pregnancies complicated by fetal growth restriction, a randomized trial showed both medications were equally safe, though misoprostol worked faster. So here's the takeaway. Favor a Foley catheter in patients with prior uterine surgery. Use oxytocin when a Foley is not an option. And remember that misoprostol and Cervidil are comparably safe in patients with an unscarred uterus. Now let's move to question number 2. Which method is the most effective? Effectiveness usually comes down to one thing: how quickly you can get someone to delivery. And there is one study that shaped a lot of what we do today: the 4-MOMI trial. This landmark clinical trial by Levine and colleagues was published in the Green Journal in 2016. The authors compared 4 induction strategies side by side: Foley alone, misoprostol alone, Foley plus misoprostol, and Foley plus oxytocin. And the winner was clear. The Foley plus misoprostol combination was the fastest approach to delivery. Later, systematic reviews confirmed the same pattern. Pairing a mechanical method with a pharmacologic agent creates a more efficient transition into active labor. This matters even more in time-sensitive situations. Think about a patient with preeclampsia with severe features. Every extra hour of induction is another hour of severe range pressures, another hour of kidney or liver dysfunction, another hour where the maternal condition can worsen. A faster pathway to delivery really matters. But what if the cervix is closed and you simply cannot place a balloon? In that case, you rely on a single agent, and misoprostol consistently outperforms the alternatives when the cervix is unfavorable. Across multiple randomized trials and meta-analyses, misoprostol produces stronger ripening effects and reaches active labor sooner than Cervidil or Foley catheter-alone in patients with a closed cervix. Mechanical methods move slowly without a prostaglandin. And while oxytocin can technically ripen a cervix, the process is extremely slow and rarely practical when time matters. So here's the practical way to think about it. Foley plus misoprostol is the most effective way to induce labor. Misoprostol alone is best single agent when the cervix is closed and prostaglandins are appropriate. Use a Foley alone only when medications cannot be used. And reserve oxytocin alone for situations where the cervix is already favorable or a Foley placement is not possible. Which brings us to the final question. Which method is the most cost-effective? Cost matters because every induction method draws from the same pool of unit resources. Even if two options work equally well, administrators still have to decide what to stock, how much to budget, and where nursing time will be spent during a busy shift. Misoprostol is by far the least expensive option. A 25 microgram dose costs around 30 cents. Even when you factor in monitoring and staff time, its total induction cost stays remarkably low. Mechanical balloons vary more. A simple Foley catheter usually costs about $5 to $10, but double balloon ripening devices, like the Cook catheter, are significantly more expensive, typically around $100 to $150. That difference shapes purchasing decisions, especially in high-volume units where many inductions happen each week. Oxytocin itself is inexpensive, often under $20 per vial. But the real cost shows up in nursing bandwidth. Long titration protocols require hands-on pump adjustments, which becomes challenging when several inductions are running at once. Cervidil is the costliest option. A single insert or gel dose often runs between $150 and $175. When you bring safety, effectiveness, and cost together, a clear pattern emerges. In patients without a prior cesarean, misoprostol consistently provides the strongest pharmacologic effect, whether you use it alone in a closed cervix or pair it with a Foley bulb when combination methods are appropriate. Misoprostol clearly rises to the top, which means the next step is understanding how to use it well. The key is understanding how the medication is absorbed. Vaginal misoprostol takes longer to peak but stays in the system longer. That is why dosing intervals need to be spaced out more generously, usually 25 micrograms every 4 to 6 hours. Oral misoprostol behaves differently. It peaks quickly and declines quickly. Because the absorption is shorter and less sustained, you can use higher doses at shorter intervals, often 50 micrograms every 2 to 4 hours. Clinically, oral misoprostol has been shown to be just as effective and just as safe as vaginal dosing for induction at term. So, how do you choose the route? Vaginal dosing works very well, but it requires a pelvic exam and relies on precise tablet placement. And that tiny 25 microgram quarter tablet is not always easy to confirm visually. Oral dosing is simpler for the patient and simpler for the team. No exam, no placement issues. A nurse can administer it immediately. And if you are a busy intern running between triage and L&D, placing the order from your workstation instead of doing another pelvic exam can help you stay efficient without compromising care. So choose the route that fits your patient and your workflow without ever sacrificing safety. Share this video and subscribe to Pathways OB GYN for evidence-based updates, teaching hacks, and smarter AI strategies. The content of this video is for educational purposes only.